Anybody on the telephone want to speak up? Let us help you identify, or let us help identify you.
That's Eric Bookbinder.
Okay, number 6. Hi, Eric.
Okay. And who else have we got on the telephone?
Rich Cameron.
Okay. I know Jim Cameron we know. We got you, Jim Cameron. Rich, was that Rich? Rich Catapano, was that?
Yes.
Okay, number 4. Rich Catapano, number 4, Jake.
Got him.
I feel like a bingo caller here.
I don't know what happened to 1 and 2.
I don't know what happened to 1 and 2 either. Well, 2 is Jim Cameron. I already.
Oh, you already got him. Okay.
Yeah, I'm just writing names, and then we'll come around to everybody in a second. Oh, and Professor Bill's with us today. I hope that Len's with us, because Len was supposed to be giving us a little presentation. Oh, well, we'll see. Jake.
We have Jerry Grimes here.
All right. Hello, Jerry.
Good evening. Dennis Correa here.
Okay. Are you catching their numbers, Jake?
I got Jerry. I didn't catch Dennis. Can you speak one more time, Dennis?
Yeah. Do you hear me now?
Yeah, no, we got
it.
Number 8. Number 8. We're just Bob and
Wait, one other person on the telephone who hasn't spoken up yet.
Jim Harrington.
Jim Harrington.
I'm on the phone.
Thanks.
Hi, Jim.
Hi.
And but we don't see Len, and Len was that's weird. We don't see Len. Well, we need to get started. Do you have Len's number, Jake?
I don't know if I do or not, Rick.
All right.
I don't think so.
Well,
His email.
Gents, just give me a second. Talk amongst yourselves. I'm just going to give Len a quick buzz to see if he's coming on, because if he is, we'll have him do his little thing first. Okay, I'm just going to go on mute.
This is Jay Kern. I got a little short question. I think it'd be pretty quick to take care of.
Go ahead.
We'll try.
Some lady's trying to sell me something from Relive, and it's multi-level marketing, and it's supposed to reduce tumor cells, among other things. Anybody ever heard of it?
I can't say I have.
No, but I'd be careful.
Did you say get a sample?
No, I would be careful.
Yeah.
Yeah.
Right. Yeah. Very expensive. $600 for just, a month's supply.
What's it called?
Relive, you said?
What do they want to sell
RELIVE?
you? What is it?
I don't know if he can hear us or he's muted or what, but I would personally be very leery of anything like that. Somebody just joined us on a telephone. Would you like to let us identify you so we know who we're talking to?
I'm Sylvester Mann.
Hey, Sylvester.
Hi.
How are you tonight?
I'm doing good.
Good. Rick's trying to he's trying to reach Len, who was going to give a little speech tonight or a little spiel, and he's trying to get through to him on the phone right now. That's what we're waiting for.
Well, I'm looking forward to hearing it. Thanks so much.
Okay, I don't find Len, so I'm afraid
Oh,
we're
wait,
gonna
here he
be
is.
guilty of
He just arrived.
Oh, he did?
Just arrived. Yeah.
Okay.
He's probably, it'll take a minute for him to log on and get recognized.
Okay. Okay. All right. Well, so we do have Len, and I'll tell him to ignore that message. And I see Peter's with us. And okay. All right. Let me see if I've got everybody. Sylvester Mann. All right. I'm going to read down who I've got, and then please tell me if I missed anybody. So I got Rich Catapano, Jim Cameron, Bill Burhans, Jake Hannum, Jerry Grimes, Dennis Correa, Jay Bob, Jeff Ledoux, Jim Harrington, Len Sierra, Peter Kapka, and Sylvester Mann. Anyone else?
Michael Robinson just joined. He's still booting up, I think.
Michael Robinson. Okay. Len, are you with us? Oh boy, I think Len was having some trouble with his with the interface between Chrome and GoToMeeting. So I don't know. My guess is he's still having. I see him on twice now.
Right.
Can you hear us, Len? He'll get in at some point. He'll get in at some point. All right. Let me go down. Let's see. Well, I should say good evening to everybody. Sorry, it's a bit of a rocky start today, but we had, as you know, Len was going to talk a little bit about, or will talk a little bit about circulating tumor cells and DNA and what exactly it is that these liquid biopsies pick up. It's a conversation that we had last week, and then it just so happened that there was a very good article on Medline, not Medline, it doesn't matter, on one of the services that I subscribe to that I sent to Len. And so he said he would summarize it and he would talk to us a little bit so that we better understand what exactly is going on when we do one of these liquid biopsies. But unfortunately, as I mentioned, Len's he wrote me, he's been having some trouble with the interface between GoToMeeting and Chrome. So I don't know exactly what the problem is. Somebody just joined us, that might be. Was that you, Len, that just came in?
No, this is Bill Franklin. I'm having a hard time getting on the web.
Oh, really?
Yeah.
Oh, we got a lot of guys on the web today. We've got 10 guys who are already on, so we're working, we're up and running, although we've got a couple of guys that are having problems, so I'm not quite sure what's going on. Anyway, let me run down, let me see who would like some time today, and then once we've done that, hopefully Len will be with us one way or the other, and we'll kick off. So let me start with Thibaut, because Oh, wait a minute. Did we lose Tebow? Are you still with us? No, I don't know if Tebow's still with us or not. I was going to say we'll start with Tebow because I know he had to leave us last time early. So, but he's not there.
He's dishing out supper right now.
He's dishing out supper, so he'll be back with us. Okay.
I was going to...
All right, let me start with, oh, there you are.
Hi.
Hi. So I was going to say, do you need some time? Because I know that you had to split last time early before we got to you.
Yeah, that'll probably happen again tonight. I don't have anything major. I did by the bone marrow team's insurance nurse verify that I was for the same insurance for the next 6 months.
Okay. Well,
Yeah, it'll work.
it's just a question of whether, do we need, I'm not going to do time now. I just wonder if you would like us to come back to you. That's all.
Oh, I see. If I'm on, but it's nothing important.
Okay. All right. So if we'll put you up number one if you're still with us when we get done with Len. Okay. Okay. Rich Catapano, would you like some time tonight?
No, I'm good. I'm just going to listen in.
Okay. Jim Cameron, how about you?
I think I'm good tonight, Rick.
Okay. Bill Burhans, how are you? Would you like some time?
I'm doing fine. So I have nothing that I need to bring to the group.
Okay, and I owe you a call, and I know I owe you a call. I'm just so slammed right now, but I'll talk to you this week for sure. Maybe.
Okay, I think you owe me about 20 calls.
I do owe you about 20 calls. Right. Mea culpa, mea culpa. You're absolutely right. Jake.
Whenever you're ready.
Jake, how about yourself?
No, Rick.
Okay. Jerry Grimes, would you like some time tonight?
Nope, nothing new tonight.
Okay. Dennis Correa, how about you?
Just listening in, Rick.
I'm sorry, say that again?
Just listening in.
Just listening in, okay. Jay Curran, I heard you, whilst I was trying to get hold of Len, I heard you talking about this this marketing. You're not the first person I've talked to about that. I have heard this scam before, and I would stay well away from it. Yeah, I mean, I did a little research when it came around last time, and I just don't see there's anything to it. It's probably the same rubbish that they're trying to sell, and it's expensive. If that $600 is burning a hole in your pocket, you can send half of it to ANCAN as a donation. We'd be very grateful. Anything else for you, Jay? Oh, we lost him. Jeff Ledoux, how about you?
Nothing much more than what we talked about in our email conversations earlier in the week.
Well, do you want to discuss that with the group? You're welcome to discuss that with the group.
Well, I'm interested in this discussion of the CTCs.
Okay. Jim Harrington, how about you?
No, nothing tonight, Rick.
Okay. Len, the ephemeral Len Sierra, do we have you with us yet?
Yes, you do, Rick, but unfortunately I'm on the phone. Once again, my software is saying that this latest version of Chrome that I have is not yet compatible with GoToMeeting.
Okay. I would strongly recommend that you you call GoToMeeting if you can. You could even call them right after, and ask them what they suggest.
Yeah, I'll do that. I forgot all about that. Yeah. Actually, I thought tonight I would just use Firefox, which I used last week.
Yeah.
And yet this time Firefox says that, well, I got the message that it's not compatible with GoToMeeting and to use Chrome.
I got exactly those same messages.
Oh, really?
Yep.
Well, I'm glad I'm not.
I use This is Jake. I use Firefox all the time, and I'm using the latest version as far as I know, and it seems to be working fine for me.
Yeah. Who's the one that said he has the same problem as me?
Jerry Grimes here.
Okay. Thank you, Jerry. Making me feel, misery loves company.
I tell you what,
The whole point of this call.
It's a little puzzling. Len, if you could give them a call afterwards and then let me know, and then I can put it in the letter next time.
Absolutely.
As to what they suggest. I mean, I know I'm using Chrome. I thought I was using the most up-to-date version. I'm just looking to see where I'm not sure how I check my Chrome version.
Go to the little 3-dot thing up in the top right corner.
Oh yeah, okay.
There's a pull down and you'll get help, and then do about.
And then do about, well, wait a minute. Well, this...
About Chrome.
Yeah, is it under settings? Help. It's under help. Yeah, I got it. So I'm using version 57.0.2987.133.
Wow, it's the exact same one I'm using.
Yep.
I'm not having any problems with that at all.
Yeah. All right, I'll call GoToMeeting.
Oh, would you? And just tell them that other people are not having a problem with it.
Interesting.
Okay.
Okay.
You might want to try uninstalling it, Glenn, and then reinstalling the new version. Sometimes that helps.
Okay, that's a good idea.
Yeah.
Okay. And Len, when we get to you, are you ready to go to talk to us about the CTCs and the SNPs and what have you? Great. So we're going to put you up first. I just want to check in with everybody, and then we'll put you up. Okay.
Sure, that's fine.
Peter Kafka, anything for you tonight?
I'm good tonight. Thank you.
Okay. Sylvester, anything for you?
Not tonight, thank you.
Michael Robinson, how about you?
No, thank you.
Okay. Bill Franklin, anything for you?
I'm good.
Good.
I called in to hear about the CTC stuff.
Okay. Tom Van Zant without a mustache. Oh my gosh.
Now that's it.
Oh my gosh. A bald-faced Tom Van Zant.
It's still there. It's just bad lighting.
It's smaller. Something's happened to it.
It's under control.
Oh, okay. That's what it is. How about you? Do you have anything you'd like to talk about?
Yeah, I had kind of a bad experience going down to one pill with food.
Okay. So, I'm glad that somebody has, because I've been through a lot of people and nobody has anything to say tonight. You're a quiet lot. So we have a couple of people on the telephone that I haven't identified. I think, is there anybody whose name I haven't called out?
This is Jay Kern, and I got kicked off the line a couple of times, so
okay.
I do have a question.
Okay, so you have a question, Jay. Okay.
Go ahead.
Did you hear my answer to your question about the pills? Stay away.
No.
It's a scam.
Yeah, I got that. I got that.
Okay. I researched it before for somebody else, and I think it's a bit of a scam. Anyone else on the telephone who hasn't identified that would like to speak up? Okay. So let's Len, the airtime is yours. You have plenty of time because we don't have many people with much to ask questions about tonight. So let's spend some time on trying to understand liquid biopsies and the little bits that are floating around your blood.
Sure. First, let me ask, can everyone hear me reasonably clearly?
Yeah, just fine.
Okay.
Excellent.
Very good. All right, so we are all familiar with tissue biopsies, which are taken from our prostate gland before anything's done to it, or from bone marrow after prostate cancer has progressed to the metastatic stage, for the purpose of identifying possibly actionable tumor mutations or genetic mutations. Now, the liquid biopsy is a non-invasive way of doing the same thing. And from what I've been reading, it sounds, Rick is probably going to disagree with this based on our previous discussions, but from what I've read, they are saying that there is a greater likelihood of using a liquid biopsy, of getting a broader scope of possible genetic mutations in the liquid biopsy, because if you're doing a, let's say, a bone marrow biopsy, all you're getting is one or a few, possibly a few clones of metastatic cells, whereas in the liquid biopsy, which could be blood or just about any biological fluid, you're getting cells, prostate cancer cells, from multiple sources, any metastatic site or any primary tumor site, if there's anything left of the primary tumor. And of course, it's non-invasive. It's, you know, as simple as drawing. So I know Rick said that he told me that the bone marrow biopsies, those samples are screened for a larger number of actionable genes than are the liquid biopsy cells. I haven't seen any reference to that in the materials that I've read. So I'm sure, you know, maybe we need to investigate that, or Rick, possibly you know the source of the information you got.
Yeah, I do. I mean, I'm happy to comment on all of this afterwards. I was going to let you finish presenting.
Oh, okay.
I have something to add to that too. This is Bill Burhams.
Okay.
Oh, we got the expert on the line. Why am I doing this?
So why don't you finish presenting, and then I'm making some notes here, and I'll say,
yeah.
And then Bill, if you could too, and then we'll make some comments after you're done, and then we'll throw it open. How about that?
Yeah, okay, I haven't got too much further to go here. So in addition to CTCs, which stands for circulating tumor cells, and these are intact tumor cells that have been shed from either the primary tumor and or metastatic tumor sites. The liquid biopsy, or the blood biopsy, I'll call it, can also extract genetic information from cell-free DNA. So this is occurring because when a cell undergoes, a cancer cell undergoes apoptosis or cell death, it releases its guts, basically, and some of that will be fragmented DNA that then circulates in the blood. That's the cell-free DNA. And then there's even other components that they can extract important genetic information. These entities called exosomes, which is a membrane-enclosed component of a cell, let's say a tumor cell, that escapes the cell and then can lodge in a fertile ground where it can develop into a metastatic site. I think they call that a pre-metastatic niche. These exosomes interact with cells that are called mesenchymal cells, and they make for a nice, comfortable environment for the genetic material that's in the exosome to be transferred to intact cells, which then become tumor cells. Now, one other thing I'd like to mention is that from what I've read, the success of a bone marrow biopsy under even the most skilled medical personnel is only about 60 to 70% with regard to having a usable specimen for analysis. Whereas, assuming you do have any CTCs in your blood, you know, that's pretty much 100% chance of having material that can be analyzed for genetic mutation. So it sounds like a win-win all around, but let's hear Professor Bill.
Well, before you do that, what about the SNPs? What about the, what is it that the liquid biopsy is actually testing? Is it testing the DNA that's in your blood, which is different, I believe, to the CTCs? I believe that the two things.
Well, first, Rick, they concentrate the blood to kind of concentrate the number of circulating tumor cells in the blood. You know, there's only normally, I think, if you have about 5 CTCs, you know, when they do the counts, that's something like 1 in 10 million cells in your blood that, you know, will represent a CTC. So they have to concentrate that before they do the analysis. Now the SNPs, single nucleotide polymorphisms, are just any kind of mutation in the DNA, most of which are harmless and useless as far as gathering information is concerned. But some SNPs or SNPs are useful as biomarkers of disease, and I'm not really aware that I haven't seen any discussion of SNPs with regard to, you know, the liquid biopsy and important information. That's my take.
So, in other words, what you're saying is that when you do a liquid biopsy, the genetic information is extracted from the circulating tumor cells, and the
circulating tumor cells, or even the cell-free DNA,
or the cell,
which I mentioned.
DNA, okay, or the cell-free DNA, and the SNPs are something different again to the cell-free DNA.
Yeah, SNPs are generally discussed in the context of mutations in the DNA structure, and they could be as frequent as 1 in every 300 nucleotides, which is incredibly high. And like I said, most of these are completely harmless and of no value as far as extracting important information.
So when they analyze your blood, they're looking either for the cell-free DNA or for the circulating tumor cells, and then out of that they may find SNPs, but they're not looking for SNPs in your blood specifically. Is that what you're saying?
I guess you could look at it that way, but you know, once again, this concept of the SNP or single nucleotide polymorphism is never even mentioned in discussions of liquid biopsies. They're only talking about CTCs and cell-free DNA and a few other components that I mentioned, like the exosomes.
Okay. And then it's
So
go ahead.
Maybe I can clarify things a little bit here.
Please.
This is Bill Burhans. So the SNPs are really, they're changes in the sequence of the DNA. And as Len has indicated, many of them are harmless, meaning that that change doesn't result in a change to the structure of a protein, for example, that's encoded by a gene. And but they are really useful, as Len also pointed out, for you know, in terms of understanding the you know, different aspects of disease. But they're really just changes in the DNA, and they can occur in DNA that's circulating in the blood independently of cells, and they occur in DNA that's in tumor cells as well. So I think the important concept here is that They're changes in the sequence of the DNA, just as are mutations, but they're not necessarily deleterious. Does that clarify things?
So in other words, this SNPs are something that you find when you do the analysis.
Right, exactly, right.
Okay. That's not the name for this this cell-free DNA that's floating around in your blood. That's just, okay. So that was...
Yeah, so the cell-free DNA will have SNPs associated with it, just as will the DNA in a tumor cell or in a non-tumor cell that's circulating in the circulatory system. It just simply refers to a change in the DNA sequence.
So let me just say a couple of quick things, and then I'm going to let Bill make his comments. First of all, I don't focus in on bone marrow as being a biopsy source. I'm not sure where that came from. I mean, normally, if you biopsy, then you're going to biopsy in prostate cancer. You're going to biopsy either bone. Well, I guess I thought they biopsy bone and not the bone marrow. But maybe I'm wrong.
Yeah, the bone marrow are the actively growing cells in bone tissue. If material or tissue other than the bone marrow is just hardened, calcified bone, and it's not useful.
Okay.
Would you agree, Bill?
Yeah, that's correct.
So if you have bone metastasis and you do a bone biopsy, are you actually biopsying the marrow that's underneath that metastasis, that cancer, or are you taking a sample of the destroyed bone that the cancer has affected?
I think this is Bill. The biopsies of bone metastatic lesions are the lesions can be in the bone marrow. I think they can also be on the outside of the bone.
Right.
The important thing is that the lesion has to have tumor cells in it, wherever.
That's right.
So it's not necessarily a sample from bone marrow.
Right.
I think this is the way that this works.
Right, and that's always been my understanding, because the cancer doesn't reach the bone marrow until very late stages.
Right, exactly.
And so if you do a bone biopsy, you're not necessarily biopsying the marrow, you're really biopsying the cancer tumor that's in the bone.
Right.
That's my understanding, Len.
Right.
Now,
okay. I had a bone biopsy a couple of years ago of a lesion that was on the surface of one of my ribs.
Right.
And what my doctors did was actually go in and take out a big chunk of the rib.
Right.
Because it was difficult to get access to the tumor because of where it was located.
Right, exactly.
It would have been difficult to get to the underside of the rib, for example, going all the way through from the back.
Right.
So that's one type of bone biopsy.
Right.
Usually it doesn't require removal of a piece of the bone. But I had a different bone biopsy that involved another lesion that was on one of the vertebrae in my spine, and that one was also on the surface of the bone.
Right.
And they just went in. The
Right. And that has always been my understanding, that they're not necessarily going through to the marrow. They are taking a sample of the bone that has been contaminated with cancer, and then they're doing an analysis off of that. Now, the point about what is more comprehensive, a solid tissue biopsy, which could be bone or it could be from visceral. Men who have tumors in visceral organs like their liver or their lungs or what have you, or the prostate, those can all be biopsied and analyzed, and those are called solid tumor. Those are called solid tumor biopsies. And the reason that solid tumor biopsies for prostate cancer are a lot more comprehensive than anything else is because the panel with which they analyze the solid tumor biopsies is about 5 times the size of the panel which they use for blood biopsies. So it may well be that a blood biopsy is more comprehensive in the sense of it covers many different tumors from different places, but it's analyzed with a much blunter instrument than the tumor biopsy. For prostate cancer, it really doesn't matter, because we now seem to think, and I will post this article in the chat window, we've talked about it many times before, but some work that was done by Pete Nelson last year up at Fred Hutch in Seattle suggests that prostate cancer tumors within the same man are identical. So it doesn't matter if you take a tumor from bone, from the prostate, from the liver, wherever that cell is broken off from, there's a greater than 90% likelihood that it's going to look exactly the same as any other lesion that's prostate cancer in your body. That's not true of all cancers, but it seems to be true of prostate cancer, which is ironic because prostate cancer itself is very heterogeneous, meaning it's different in every man. So whilst the prostate cancer may vary significantly from man to man, and maybe, well, it could be different in every single man. We don't know, but it's very, very heterogeneous. Within that same man, doesn't matter where you biopsy, it's always going to look pretty much the same.
Okay, so can I interject a few things here, Rick? I don't think that's quite the way it works. You're correct that metastatic lesions are quite homogeneous. They look very similar. But the primary lesion in a prostate cancer patient is quite heterogeneous. And so that's really the big difference. It's not that it's heterogeneous from patient to patient. It's that if you take a sample from the primary tumor, if you take 3 samples from the primary tumor, they're all going to be different, which is quite different from metastatic lesions, where if you take a sample, 3 samples from the same metastatic lesion or from 3 different metastatic lesions, they're all going to look fairly similar. Is that clear?
Well, I'm not sure I agree with you, Bill, because I know that I've asked some of the doctors, and resulting from this Pete Nelson work, they seem to suggest that there is homogeneity, no matter where you take it, including the prostate. But this is...
I don't, you could be right, Rick. I don't think that's the case, but I'm going to look into it further and I will get back to you.
Give me a second, keep talking, and I'll post the article. You can take
Okay, so the other point that I wanted to make was that in terms of the number of, I can't remember how you put it, Len, you were talking about how different types of approaches to sampling will generate a different number of genes in the genetic report. Was that basically what you were talking about?
A different number of tumor mutations. In other words,
okay,
if you do it, in a way, it kind of agrees with a little bit with what Rick was saying about the homogeneity of metastatic sites. In that, you know, if you take a sample of a metastatic site, you're likely to see the same genetic mutations. But then, as you said, Bill, and I think I thought you were right, at least, about the primary tumor is more heterogeneous in its tumor mutations, and so if you're doing a liquid biopsy, you're getting samples of metastatic sites as well as primary tumor sites, i.e., the prostate gland itself, assuming it's still there.
Right.
Yeah. And I just want to say that my comments really are based on an article in Medscape that Rick asked me to kind of read through and then present to the group. And unfortunately, the article, although it talked about liquid biopsies, the focus was on non-small cell lung cancer, which is a very highly heterogeneous tumor, unlike prostate cancer.
Yeah, okay.
So it could be that those advantages of the liquid biopsy that I spoke of are not necessarily applicable to prostate cancer, but more to a cancer like lung cancer.
Yeah, okay, that might be the case, but I think it's, you know, to a certain extent, it's also the case that it gives you a broader picture. You know, if I'm correct about the primary tumor as being quite heterogeneous, then a liquid biopsy is going to give you a more accurate picture of that heterogeneity, because you're looking at many different DNA from many different cells rather than from the small number that you would get from a biopsy of the bone itself, for example. But
right.
The other consideration for in comparing liquid biopsies with more conventional biopsy is that at least Foundation 1, the panel of genes that are screened for DNA recovered from liquid biopsies, so DNA either recovered from circulating tumor cells or cell-free DNA, either one, the panel of genes that are screened is only about 60 genes, or at least that's what was the case up until the last time I looked about 6 months ago. Where in comparison, the panel of genes that's screened for DNA that's recovered from a conventional biopsy is on the order of 300 or more. And so you get, in that sense, you're able to, they're able to basically query or interrogate many additional genes in the case of a conventional biopsy compared to a liquid biopsy. So that's something.
Why is?
I'm sorry.
Yeah, I'm sorry. I thought you were pausing there. Why is it then that they are only screening 60 genes from a liquid biopsy versus 300 from a solid tissue biopsy?
To tell you the truth, Len, I don't know what the answer to that question is. I suspect it has something to do with the difficulties in getting sufficient quantities of DNA to actually do the screen at all. I mean, in the case of the liquid biopsies. I mean, the technology that's involved in liquid biopsies is just incredible. When you consider the fact that there are billions, maybe trillions of cells in, you know, the 7 liters of blood or whatever it is in an adult human being, and the liquid biopsy that recovers tumor cells, for example, isolates them from just 7 milliliters of those 7 liters or whatever it is. Don't hold me to that number, but it's a much larger number than 7 milliliters. But so it's basically they're looking for a needle in a huge, huge haystack, and yet the technology is capable of doing that. So, for example, when I had a circulating tumor cell screen a couple of years ago, they detected 1 tumor cell in the 7 milliliters of blood that they withdrew for the assay, and so, you know, that's against the background of a huge number of normal cells, and yet they're able to do it, but it still has to be very difficult to, I mean, you know, that's 1 cell's worth of DNA in every 7 milliliters, and that's very little DNA to use in the screen looking for mutations. So I think the answer is related to that very small amount of DNA, which is not quite as much of a consideration for a conventional, for the DNA that's recovered from a conventional biopsy. Does that all make sense?
Yes, I suspected that was the reason, but I'd never heard or read that explained in the way you did, but it certainly makes sense.
Yeah, okay. So, yeah, and I think, you know, for anybody that's listening in, you know, if you're considering going the liquid biopsy route, it certainly, you know, has all the advantages of compared to a conventional biopsy that involve, you know, there's no risk of infection, it's a lot less painful, you know, I mean, I think everybody is aware of the issues involved with a conventional biopsy. So they're far superior from that point of view. But the fact that they can only query, you know, a panel of 60 genes compared to the 300 or more, you know, that's a big consideration. It means that it's possible that they may miss mutations in genes that are not within the panel, in the case of a liquid biopsy, that might be important for, you know, in understanding your particular tumor.
So just a couple of things to help you all. I posted some articles, 2 articles in the chat window, and I'm going to tell you one of them is much better than the other, and for those of you who are on the phone, I'm going to give you the name of that article so that you can track it down. It was published on February 29th, 2016, Sadie Hawkins Day last year. So, Feb 29th, 2016. The article is called, "Is Metastatic Prostate Cancer Tailor-Made for Precision Oncology?" And it was published in the Hutch News, H-U-T-C-H, Hutch News, which is a publication from the Fred Hutchinson Cancer Institute at the University of Washington. So those of you who are on the phone, make a note of that. Is Metastatic Prostate Cancer Tailor-Made for Precision Oncology, from the Hutch News on Feb 29, 2016. Those of you who are on the web, you can see the link. The second article is sort of a summary of the first one. I've also posted for you a very good little video that Foundation Medicine puts out about how the liquid biopsy is, it's an animation rather than a video. It's a little animation. It's about 2 or 3 minutes long. And it shows you how they go about finding the tumor cells to analyze for the liquid biopsy. I watched it some time ago. For those of you on the phone, it's a fairly simple URL. So if you've got a pencil, I'm going to give it to you. It is www.planetnutshell, all one word, planetnutshell.com/portfolio/foundation-act. I'll repeat that. www.planetnutshell.com/portfolio/foundation-act. So you can take a look at that, and you'll know as much as I do about how the how this all works, the technicalities that is of the liquid biopsy. Earlier on, by the way, if you were watching the chat window, Jeff Ledoux had asked me to provide the links for the UCSF nutrition pamphlet on prostate cancer, which I did. It has nothing to do with what we're talking about there, but it is on there. And speaking of Jeff posts a question for Len or Bill. He says, why were there not enough CTCs to run the ARV7 splice variant test at Johns Hopkins in my own case? So they went to, Jeff sent a blood sample down to Hopkins lab to look for ARV7. It wasn't a genetic test, but there weren't enough CTCs. Bill, I have an idea, but Bill, do you want to talk about the volume of CTCs in the blood cells, in the bloodstream, and how it gets there?
Well, as little as 1 CTC per 7 milliliters of blood. So, these tests are all done with a blood draw of just 7 milliliters of blood. So that gives you some idea of how many, what the lower limit of the number of CTCs is in the entire body. So, if we stick with my 7 liters of blood again, and once again, this may be wrong, but it's within, an order of magnitude correct, then 7 milliliters is going to be about 1,000th of that. So you're talking about a lower limit of detection of about 1,000, roughly 1,000 tumor cells in the entire body. So my guess is that the reason why there weren't enough CTCs to do the analysis for the splice variant is that it just simply requires more than what they were able to recover. Do you know how many CTCs were actually recovered? That should have been in a report that you received at some point.
Did not see that in the report.
Okay, if you go back to the report, and it should be there, because generally the rule of thumb is that if there's less than 1 CTC detected, well, if no CTCs are detected in that 7 milliliters of blood, then that generally means that your prognosis is probably going to be pretty good. And if there's more than, if there's just 1 or 2, then it's also not too bad, but it's not quite as good as if there are 0 in that 7 mils. But then when the number of CTCs approaches somewhere around 5 to 10, per 7 milliliters of blood, then that, points towards a worse prognosis. So CTCs are counted largely to make that kind of, to develop that sort of information, prognostic information. So that information should be in the report somewhere. And if you can find that information and email it to me, I can, perhaps give you a more careful description of what I think the reason why there wasn't enough is.
So, I mean, a normal level, I don't say a normal level, but usually they're looking at around 4 to 5 CTCs per, I don't know per what, but per blood draw, whatever it is, if it's 7 milliliters.
Yeah, 7 milliliters, yep.
So they're usually looking around 4 to 5 as being indicative of metastasis, but not that doesn't indicate a exceptionally heavy tumor load, but it's usually enough to do any analysis. As the tumor load increases, meaning the more metastasis you have, then that number increases significantly. And I remember that with Dom, God rest his soul, soon before he passed, his number was up around 18.
Yeah, right.
Scary. So, one possible reason why, as Bill said, that Jeff doesn't have enough CTCs is because, thank God, he doesn't have a very heavy tumor load. There isn't a lot of metastasis in his body, which means there's not a lot of cells splitting off, shedding off of the tumors and getting into the bloodstream and circulating around. And the more you have, the more CTCs you're going to see in the blood draw. Let's open it up for questions. Who has a question that they'd like to put?
I'd like to ask a question. This is Peter. I just put it in the chat box, but I'll ask it personally anyway. Can you hear me?
Yes. Yeah.
This is I guess this is directed to Bill or to anybody, all of you, I guess. Is the laboratory,
as much as I do about this stuff,
right? Is the laboratory analysis of these panels an objective test or a subjective test? If it's subjective, does it need to be? Do we need second opinions from other labs? How do they go about this? Is this fail safe? That if a genetic mutation is found, it's definitely so, or mistakes made?
So, Len, do you want to take it? Do you want me to?
Oh, no, this is an area you know much more than I do, Bill.
Okay, I'm not so sure that's the case, but I'll go ahead and take a shot at it. So what is the objective part of the analysis is the number of tumor cells that are recovered. So, whatever that number is, that information is objective, and the interpretation in terms of prognosis is fairly objective too. And that, specifically that means that I think pretty much everybody agrees that if if no circulating tumor cells are detected, or just 1 or 2, or even 3 or 4, then the prognosis is pretty good. And anything beyond that, the prognosis gets progressively worse. And as Rick pointed out, that's largely because you're now looking at cells that are being shed from metastatic lesions in addition to their primary tumor. Where it becomes subjective is when they find mutations in the DNA that's isolated from these cells. And it's sometimes difficult to, to put a really solid interpretation to the significance of different mutations. Does that answer your question, Peter?
I think so. Yeah, I think it does. So this is not something like an initial biopsy to determine whether you have prostate cancer or not, which is counting cells and you know, it's common practice to go get a second opinion on the pathology. But it doesn't sound like this is common practice to get second opinions from another lab.
No, you wouldn't get a second opinion on this. In fact, I think that the technology for isolating circulating tumor cells may be specific for one company. And all the, I'm not certain about this, but I think that whenever you know, blood is drawn from a patient, it eventually gets sent to the same company, and they, you know, so they're doing the analysis for everybody that has this type of assay.
Well, let me drill down on that one a little bit. I actually think that there are different companies that do liquid biopsy tests.
Yeah, you could be right, Rick.
I mean, I know of at least two. I know that Guardant does it, and I know that Foundation Medicine does it. And then there's another company. What's the company that Snuffy likes, that he always sends his people to? I'm just looking for their brochure here. It begins with a C, I think. Anybody remember the name of that company? It's just escaping me right now. But I mean, there is another company that's out there. There are several different companies. Now, I guess that one could take a blood draw, and if one had the money, Caris, that's it. So, some of you may have heard of Caris. So I'm sure you could send to each one of these, and you could figure out which one has the best test. I've got a feeling that Caris might be just for germline, for genetic, and whereas Guardant and Foundation Medicine are genomic for the tumor. And maybe they pick up different mutations. I don't know. I've never really thought.
I don't know. You wouldn't be using circulating tumor cells to look for a germline mutation. I mean, that's a, you know, right. you just you isolate blood cells and look, you know, for the
but
mutation.
I agree. But I mean, I'm just saying, I think Caris, I think I probably misspoke. I think Caris is just a germline company, whereas Guardant and Foundation both do genomic testing. And, and I think that Guardant only does liquid, works only from a liquid biopsy, whereas Foundation works from a solid and a liquid.
Right. Yeah, I still think, I know that there's more than one company that actually does these types of assays, and I maybe didn't explain this as clearly as I should.
Mm-hmm.
The underlying technology, though, was developed by a single company and patented. And I think that, you know, Foundation One or Caris, for example, or, you know, whatever other companies do this type of analysis, when they do it, they're using the same technology. And the result is going to be pretty much the same. I don't think that it's going to be terribly variable. So, you know, the bottom line is, I don't think that for this type of, you know, of an approach to looking for genetic changes and how they might relate to your tumor, you know, it's going to be pretty much the same no matter who you go to. Where the, you know, where things get foggier is when you start looking at what the mutations are that they find,
right,
and start discussing the significance of those mutations.
Right. I mean, I'm looking at the Guardant. I mean, I know for certain that that Foundation has the liquid biopsy test, and I'm reading the Guardant literature right in front of me. So the Guardant 360 liquid biopsy provides the genomic analysis with a simple blood draw. This is the for those of you who are online, this is the Guardant brochure, so, but I don't know what the size of their panel is, and they say 360. That would lead one to believe it's 360. 360. What would they be? Mutations? What 360 what, Bill? 360.
That would be 360 genes.
Genes. So they say, you know, but I don't know if that's the case. I honestly don't, and they don't say that anywhere. So maybe. Oh, here we go. Garden,
almost certainly that's what it is.
70. Garden 360 searches for cancer-relevant portions of 70 genes. So, you know, you've got 70 genes with Guardant, you've got 60 genes with Foundation. Whether they use the same technology or not to extract the cancers, the CTCs, Bill seems to think it is the same technology, so we'll go with that. Who else has a question that they'd like to ask?
I have a question. This is Jake. Bill mentioned, you know, the difficulty of getting a sample from a bone, from a rib. And I think Steve and a couple of other people have mentioned it in the past. Do circulating tumor cells escape from bone-only cancer, you know, that hasn't spread to the liver or to the lungs or whatever? If it's only in the bones, do the circulating tumor cells actually escape from that? Did they can be measured? And does anybody know?
I'm sorry, go ahead. Circulating tumor cells can arise from any kind of a metastatic lesion or from the primary tumor. It doesn't matter whether or not the metastatic lesion is on bone or on liver or in the bone marrow or not. You know, one of the properties of metastatic of cells in metastatic lesions, you know, one of the defining characteristics of a metastatic lesion is that the cells are, you know, are not as sticky as they are, if that's the right way to put it, in a primary tumor. You know, they tend to break off more easily and enter into the bloodstream.
Okay, because that's how it becomes metastatic in the first place. It spreads through the blood, right?
Exactly. Right.
Okay. All right. Thank you.
Rick, this is Len. Just one comment or question, I suppose, for Bill or for everyone. We were speaking earlier of the potential superiority of traditional biopsy of bone or maybe visceral, where they're screening for 300 genes compared to whatever the number was, 60 for the CTCs, you know, for the liquid biopsy. So my question is this: given that there are probably less than 10 known actionable genes, does it really matter if the liquid biopsy is screening 60 genes and the traditional biopsy is screening for 300, if, you know, very few are actionable anyway, and therefore very few would have any therapeutic implications?
Oh, that's a really good question, Len. And I'm not sure what the answer is, other than that, you know, you got to hope that the 10 genes that are in fact actionable are in both panels. So that, you know, you're going to be able to take advantage of them. But it's also the case that, you know, some of the other ones that aren't actionable now could become actionable in the future. And so it's worth knowing whether or not you have mutations in those genes too, you know, if there's any possibility that, you know, a drug is coming down the pike that would be capable of being used against those too.
So. Right, I think you're right about that. That makes sense. I think in the past, within the last 6 months, Rick actually got sample reports from Foundation Medicine one was a sample of the liquid biopsy and one was a sample of a tumor, of a biopsy.
Right.
And you know, so we could compare. I think I'm the one that asked to see that. But you make a good point, Bill, that, you know, maybe down the road they'll be able to find, even though there may not be, it may be similar in terms of actionable genes now, maybe down the road they'll be able to find more. I don't know. But
Well,
didn't you have it posted somewhere, Rick, on ANCAN?
I can't remember if we posted them, but I'll try to find a place to post them for you. I've definitely got them. If anybody wants to see the reports, they should email me because we have them, but I don't know if I put them up on the web. I mean, I can do. I just there's a bunch of resources I have to put on the web, and I just haven't gotten to do it. But there is one. I do want to respond to Len's question. Len, we know that there are 10 actionable genes, but we also know that a lot of these panels screen for specific mutations within the pathway of those genes. So, for example, BRCA has certain mutations that show up in the pathway, and we can identify some of those mutations when we screen. So then, even though, and Bill, maybe you can explain this a little better, but there may be only 10 actionable genes, but there's many different combinations that they screen for within each gene. Isn't that right, Bill?
Yes, I don't know. I wish that I knew what those 10 actionable genes are. So you may be right, but you know, I think that the general concept that you're putting out there is correct. I mean, the BRCA gene exists in a network of genes that are all involved in DNA repair, for example.
Right.
And so, although initially, you know, drugs like olaparib, the PARP, or you know, and other PARP inhibitors were developed because they, on the basis of their ability to interact with mutations in BRCA genes, it became clear later on that you know, ATM is another gene that's in DNA repair pathways, in the same pathway as BRCA genes, and olaparib works, you know, pretty well in patients that have mutations in ATM as well.
Mm-hmm.
So you're right. It's, you know, BRCA may be the one that's actionable, but then there are, you know, many other genes that are in the same pathway that might be actionable too.
Right. I mean, I'm thinking of like CDK12, which is what Dom had, which was somehow or other in the BRCA pathway. So they thought they would try him with olaparib.
Right. Right. I don't know if CDK12 is one of the genes that are considered to be actionable. Do you know, Len?
Yes, it is. It's a DNA repair gene mutation, but it's a gene, Rick. I mean, what you're talking about, the BRCA2, the CDK, the PD, what is it, PD1, you know, those are genes. And yeah, they're involved in ways that can cause...
More than 10, because I could probably recite from my tiny little bit of knowledge, I could probably figure 7 or 8 of them. And I just, so few.
I should not, I should have said a handful. I don't even know how many there are. Maybe there are 20. I really don't know. But my point was that, you know, I assume that the 60 genes that are chosen for the screen with a liquid biopsy would encompass all of the known actionable genes. That's my basic point.
Well, I don't think they do. I think that's the point. I think the point,
okay.
I think the point is that there are more actionable genes than are tested for in the liquid biopsy.
I don't think that's true, Rick.
No.
That's why we asked before for the Foundation 1 studies to compare the two. And even though there was a lot more that were identified, obviously in the you know, a lot more genes tested, there's no actionable genes yet that they know of. So I think they are pretty much comparable. At least that was the conclusion I came to.
What do you mean there aren't any?
We talked about this about 6 or 7 months ago.
You're saying that there aren't any actionable genes in prostate cancer?
No.
No.
Okay.
The comparing we're talking of Foundation 1 only now.
Okay.
We asked for a sample of the full scale test and one of the blood biopsy only.
Yeah.
And then each one only listed at the time, this is 6 or 7 months ago, and probably technology has changed since then, but at the time there was only 3 or 4 that were identified as being actionable at all.
Right.
That they had a drug that they could recommend to try this or try that. Am I remembering that correctly, Rick? Am I recalling correctly?
I thought there were more. I just thought there were
No, I don't think so, Rick. There are very few. And I think, Len's point really is an important one. There certainly aren't 60 actionable genes in prostate cancer. And yet, so that means that when you have a liquid biopsy, DNA from a liquid biopsy analyzed, and they're looking at a panel of 60 genes, most of those genes, as Len was pointing out, aren't going to give you information that's going to be useful in terms of, picking a drug off the shelf that's going to work against it.
Well, a couple of things. One is I will reach out. We actually met with the Foundation Medicine folks last Wednesday, Steve and myself, on an unrelated issue.
Okay.
And I will reach out to one of them and I will ask them specifically whether there are actionable genes that could be discovered in the solid tumor biopsy that would not be discovered in the liquid biopsy. I mean, we actually discussed it at the table, and it seemed like they agreed that you would find more actionable genes from the solid tumor biopsy. But I stand corrected. Talking about stand corrected.
No. If you're talking about genes that might be found to be actionable in the future, then yes, that the solid biopsies give you more to work with.
I don't want to sort of dissect semantics, but to me, an actionable gene is a gene that's actionable now. I mean, you can't identify an actionable gene if you don't have anything that will work on it. Otherwise, by definition, it's not actionable.
Right. So, okay. So if you go back and talk to these guys again, I'd be interested in knowing.
No, well, definitely. I mean, I'll reach out to the to the 2 guys I was with. Now, the other thing I just want to mention is that we are on May the 10th. We're going to have a presentation. It's not going to be prostate cancer specific, but Bill is going to be on the panel. And we're going to be talking about genomic testing and biopsies that will include the liquid biopsy. And there will be an ability to ask questions. And I think this is probably a question that we should be asking. Is a solid tumor biopsy redundant? Because all of the possible actionable genes for your cancer, whatever the cancer is, are contained in the liquid biopsy. And we'll find out. It may depend on your cancer. It may well depend on your cancer.
Yeah, this is a good question. Yep.
Yeah, that
and
is.
So we will definitely include that, and when we talk to those, when we talk to people, and I will make sure you all get information. But it's going to be a Cure Talk panel. It's going to be on May the 10th at 6 o'clock Eastern. Isn't that right, Bill?
Yeah, that's correct.
Yeah, 6 o'clock. 6 o'clock Eastern. It'll be a 1 hour, and it'll be a great panel with. I'm going to moderate, but there's going to be a couple of doctors, one from Foundation Medicine, a couple of patients, including Bill, and and David Marshak, who is the Director of Patient Advocacy, and Mike Scott from Prostate Cancer International, who has a slightly variant view of on the value of these biopsies, which is concerning the Foundation Medicine folks enough that we have to make sure that we don't get sidetracked. But I personally like the idea that there's going to be somebody saying, are you sure you want to get a genomic biopsy or what have you? Because we always talk about the positives. We don't talk about the negatives. Somebody needs to talk about the negatives because maybe there are some. And
right.
In the spirit of fair speech, I think it's good that we'll be able to address that too. So we
is there any way of getting a garden representative there also?
No, there isn't.
Okay.
There isn't. Unless anybody else has questions, we've only got a couple of people who wanted to raise issues today. And so, which is why I've let this conversation go on a lot longer. It's interesting, it's beneficial. If there's anyone else that's got anything pressing on this subject, speak up or forever hold your peace.
Yeah.
Yes.
I do. That article that you linked us to by Dr. Pete Nelson, he's quoted in that Hutch News. Let me just read this, just one sentence. It says, unlike initial tumors in the prostate, in which molecular characteristics can vary by location, you can read that as heterogeneity. The tumor cells that break free and travel to distant locations within the body, forming metastases, appear to share characteristics, and that you could read as homogeneity. Right. So it's the metastatic sites that are homogeneous, and it's the prostate that can be heterogeneous.
Right. I agree. I wanted to I wanted to correct myself. It went across my mind to correct myself earlier when I said I stand corrected. I was going to add for that, but we got sidetracked. Yes, I read that during the meeting just now too, so I agree with you. I stand corrected on that.
And Rick, the second article makes it more explicit. It says primary tumors which can be very heterogeneous.
Right.
So,
right.
So I'd like to make one more comment before you move on, and it's just a little bit of an aside. Len, you mentioned exosomes as a third source of DNA to look for mutations in. And I just wanted to tell you about a very short story about how when I was hospitalized at Sloan Kettering about 3 years ago to have a different non-prostate tumor removed from my leg, I had a good friend from graduate school who's on the faculty at Sloan Kettering. He's a pediatric neuro-oncologist. And knowing how bad the food was at Sloan Kettering in the hospital, he brought me chicken soup every day. And you know, we talked science. And actually, I visited his lab after I was discharged, and we talked science some more. So he actually is his lab was the lab that discovered exosomes. And and he subsequently discovered that they contain DNA. So this is a totally new area, and it may turn out to be much more fertile in terms of understanding or looking for mutations than either circulating tumor cells or DNA that's floating around in the bloodstream.
And remind us again what exosomes are. Bill, remind us again in simple language what exosomes are.
Okay, exosomes are particles that bud off of tumor cells. Mm-hmm. And so they have a membrane that's made up of from the cell membrane from which these things budded from. And they contain RNA and proteins, and very recently they were determined to have DNA as well. So they bud off from tumor cells, and then they circulate throughout the body until they find the appropriate metastatic niche, as Len described it, and then they hone in on that and deposit their load of protein and RNA and DNA, and that largely is responsible for the development of subsequent metastases.
All right. Okay. Okay. Well, thank you. How good was the chicken soup?
It was great. It came from someplace on First Avenue, right outside the hospital.
Okay.
And my wife and I, I continued to be a patient there for about another year. And when we went back down there, we go there and get more of it. So it was pretty good.
Well, I hope I have the chance to offer you my chicken soup at some point in time, Bill. It's very good.
I hope so too.
Oh, guys, this is Peter again. I just want to bring up my situation. I did a recent germline test rather than genomic, and the results came back and showed me that I did not have particularly any genetic mutation positively related to prostate cancer, but I did have a mutation that gave me a proclivity, 45% proclivity to other cancers. So I think it's just, in my mind, it just means don't narrow the search too small. If you're looking for one thing, if you widen it a little bit, you might find something else that could be useful and give you a heads up on it.
That's a good point.
That could also needlessly worry you about another cancer that you may never get anyway.
You're right. You're right.
Well, it's the good news and the bad news, but when they find a gene that is heavily related to frequent incidence of a cancer and you can be screened for that cancer, I think it's very wise to be screened for the cancer. In Peter's case, he had a gene that was within the realms of Lynch syndrome, which is associated with a number of cancers, but most frequently colorectal, and also does have some association with prostate cancer. We're not too clear exactly what that is, but we do know that there is a relationship there. But the indicator is that Peter and particularly his boys, who obviously are significantly younger, should get more frequent screening for colorectal cancer, for colonoscopies. So, on the one hand, you can say, well, it would worry you more. On the other hand, what I say is, if you can screen for that cancer, that you have a greater likelihood, do it.
Yes, I agree with that. But I remember there was a story in the news about people who had, total genome studies, and they were told, well, you have, this percentage chance of developing, let's say, breast cancer, and then some women would go ahead and have like a prophylactic bilateral mastectomy. And, maybe it was smart, maybe not. Maybe they never would have developed breast cancer. There's some tricky issues.
Well, yeah, but Len, it comes back to the whole issue of PSA testing, which again is obviously very topical this week. And these tests are oftentimes about information. They're not about treatment. And if somebody decides to have treatment based on these tests, they need to have discussed it extensively with their medical team. The test isn't telling you to get treatment. The test is telling you that there may be a problem. And, I was on the radio earlier this morning with calling in because they had Bibbins Domingo on the talk show here in the morning about her report, her USPSTF report. And the point to make there, and all of you, if you want to listen to that, it's a half-hour segment. It's on Forum, F-O-R-U-M, on KQED, and it can be heard on the recording anytime off the internet or the podcast. And I did get on and I said what I needed to say. But the point is, don't not screen. Just be careful what you do with the information. And there's not one person on this call who would say, oh, you know, you shouldn't do PSA testing because it leads to overtreatment. No, PSA testing does not lead to overtreatment. PSA testing leads to information which, if treated wrongly, can cause overtreatment. There's a huge difference. And so, you know, I'm sensitive about how we interpret these tests and what we do with the information. And all too often we blame the test when we should be blaming the medical professionals. At the same time, some of you may have had the opportunity to see, or if not, I recommend you do watch a movie that's available now on YouTube called Pink and Blue about the inherited BRCA gene. Bill and I are familiar with this movie. You can now watch it on YouTube. And there are young women of 19 years old in that movie who demand a double mastectomy, or at least one, because she saw her mother die from an inherited BRCA gene. This is something that is near and dear to Bill's heart. But it was very hard for her to find a surgeon that was willing to do that procedure for her. But she was clear in her own mind that's what she wanted. So, as Len says, it's a tricky issue, but don't blame the test for the treatment.
I agree 100%, Rich.
Let's just get to the couple of people that did want to say a couple of things. If they're still with us, I know I've got Jay Curran, who I think might have hung up. I don't think he's still with us. And Thibault, are you still with us?
Yeah, I'm here.
Great. So why don't you just give us a quick update? I don't even think Bill may not even know about this test you're doing, and I'm sure he'll be fascinated to hear it. So give us a quick update on the trial you've been accepted for, and then we'll go to you, Tom Van Zandt. But give us your update this week, Thibault.
Well, the paperwork is moving along very slowly for getting me into this clinical trial, which involves bone marrow transplant from a female relative. And then they follow that up with bipolar androgen therapy. My insurance company has agreed to pay. The hospital has verified that I'm going to have that insurance for the next 6 months, and now I'm just waiting on them to send me some questionnaire where I guess I answer questions like, who are your female relatives? We can start testing them. Mm-hmm. And I've got an appointment with Tonarakis next week. I'll just ask him, you know, if this doesn't work out, what's our plan B? And I want to talk about, well, does anybody have any questions about that before I move on?
Yeah,
this is Bill. I'm very interested in the bone marrow transplant. But maybe you could, perhaps you could send me the identification number for the clinical trial in an email, and I can look it up rather than take a lot of time here. Thibault, did you hear that?
Trials.gov. If you just search on bone marrow transplant prostate cancer, I'm sure you'll find it. It's through Johns Hopkins in Baltimore.
Okay. All right. I'll dig it out, and I might double check with you to make sure that I've got the right trial.
Yeah. It's with, the main guy is Dr. Denmead, the same guy who's been doing bipolar androgen therapy for the last year.
Okay, great.
And that's who spoke to us. So Bill, I think you're already connected to Sam Denmead.
Yeah, that's right.
So you could certainly send him a note and ask him for more information on it.
Yeah, okay.
So I read a news story just yesterday about the way they do these bone marrow transplants. You had to have a match between these like 10 genes to do a bone marrow transplant. So if you didn't have a sibling, this new way, they only need like half of it to be matched, and they've got this procedure where they kill off the mature T cells that don't match, and then the other ones grow into the matching type or something. It's pretty new, and it allows a lot of people to get bone marrow transplants that wouldn't have otherwise. But the chance of dying from the process are slightly more. It's about 10% rather than 5%. I'm hoping that the people they've done before started out less healthy than me, and I've got a better chance than that.
Yeah.
Other issue.
What is the goal of the bone marrow transplant? Or is the idea to enrich for a population of immune system cells that would efficiently attack the tumor? Is that?
Not depending on the chemotherapy before the bone marrow transplant to kill the prostate cancer. They only use a little bit of chemotherapy to facilitate the transfer, and then they're expecting the new immune system to do the work.
Yeah, okay. So it's basically an immune system transplant.
Yeah, right.
Okay, it sounds very interesting. I'm going to look into this further.
So, Bill.
So yet. I'm patient number 1, phase 1 trial.
Okay. Well, good luck with it.
He's our man. Bill, I've just posted, there are 2 trials that show up.
Oh yeah, I see it. Okay, great.
I posted one, and let me just look at this other trial. Oh, the other trial's in London. So this is they're probably related, the trial at Queen Mary's and the trial at Johns Hopkins.
Yeah.
So, but I'll give you, I'm going to give you both numbers, and then when you come back on, you can give us your wisdom on it next time. But the first one is the one that Thibaut's looking at. The second one is the one at Queen Mary's London.
Okay.
Okay.
Terrific. Yep, I got them.
And I also just wanted to mention, by the way, that Jeff Ledoux responded and said they didn't find any CTCs when they did his blood draw, which is a good thing.
Yes, right. But that explains why they couldn't do the test. You got to have something to run the test on.
That's right. So, Thibaut, what else? Did you have anything else you would like to mention? You had said there was a couple of things.
Yeah, I wanted to talk about my latest pain issues.
Mm-hmm.
I had some shoulder pain and foot pain and lower back pain from a long time before, probably not related to the cancer. And when I had this ketamine infusion, those pains, at least in the shoulder and the foot, pretty much went away for 4 months. It was like magic. And then the pain started to come back, and I got this I have bone metastases in the area, and they've been there for about a year. But it comes and goes, so I'm not sure. I got from my primary care doctor, but I found that it doesn't work as well as ketoprofen, which is an NSAID like ibuprofen or Aleve, but and it's not currently available over the counter, but it was like 10 years ago, and it worked so well on my headaches at that time that I bought a bunch, and I still had some left over, and I tried it on my back, and it works fast, and the pain is gone for like 3 or 4 hours, which is better than Aleve or Percocet or Vicodin. And so next time I see him, I'm going to ask for some more ketoprofen pills. In the meantime, I learned that pain patches are popular in other countries, including ketoprofen, and you can get them over the counter. So I ordered some over-the-counter ketoprofen pain patches from Japan a couple weeks ago, and they just arrived today. So I'm going to try that out and see how it works. It should allow me to use as many patches as I want without risking. It should allow it to work with less risk of stomach problems and problems. But I haven't tried it yet.
So, do we know what exactly ketoprofen is?
Well, it's generally used for like arthritis in horses.
Oh.
Other end.
How do you spell it?
Ketoprofen.
Yeah.
It's an NSAID, just like ibuprofen, which is Advil.
Yeah.
Same class drug.
Okay, good.
Magic for me.
All right.
Yep, thanks.
Yeah.
I'm going to look into it.
Yeah, I'm just about to. I've put it in the chat. I'm just about to put it in the chat window with the Wikipedia link for you guys. And for those of you who are not on online, it is, again, it's spelled Ketoprofen. I just wonder to what extent one's own genetics affect the how well a drug works for you. Whether there's a personal aspect to every drug, as it were.
I think there is. I saw a study where they compared ketoprofen to naproxen, and they found some people preferred naproxen and some people preferred ketoprofen, but more of them preferred the ketoprofen.
Well, I'm looking at ketoprofen on Wikipedia, and it's got all those little hexagons that people like Len and Bill understand. To me, they're just pretty patterns. But you guys are the chemists around here, so it'll mean something to you. But thank you for sharing that, and I've made a note of it, and I definitely will bear it in mind so that when we get men on the call who are complaining about pain and looking for something that is not an opiate, that this is something that might be worth their while trying. So thank you.
Can I ask a question, Rick? Does anybody know? This is Jake. Is it true that patches are not as dangerous to your liver as a pill? To liver and stomach? Is that true? Does anybody know?
I found
I would
kind of medicine.
Yes.
For your stomach. I don't know about the liver, because if it's absorbed through the skin, it's going into your bloodstream, and it's not going through your gut. It's not going through your stomach. So there should be less incidence of gastric ulcer, for instance.
But not so much on the liver. You still have to worry about the liver dose.
Yeah, I'm not sure about that, actually, Jake. I'm not sure if the patch completely bypasses hepatic metabolism or not.
Guessing that it will affect the liver.
You have to read the entire, patient insert.
Okay, I was just curious. Thanks.
Yep.
So this is a good segue to get to Tom Van Zandt, who I think wants to tell us that he's cut back his abiraterone, but taking it with food hasn't exactly been what he expected. Is that right, Mr. Van Zandt?
That is true, yes. I had heard that you could cut the dosage if you took it with food, and I mentioned it to the oncologist on March the 6th, and he said, yes, you could do that. Just take 1 pill a day with food. So I began doing that on March the 6th. And little by little by little, I started feeling worse and worse and worse. And it seemed like it wasn't a very good idea, but I stayed with it until April 14th and got a blood test. I don't have the results of that yet. I imagine my PSA was going up, but I'm back on 4 pills now and slowly starting to feel better. And that's the end of my little experiment.
Have you discussed this with your with the doc?
Yeah, it's interesting. I discussed it with the oncologist at Fox Chase, but he's not the one prescribing the pills. The VA doctor is the one prescribing the pills. And I didn't discuss it with him because I know he wouldn't have liked it. So,
well, but
we'll see.
I think it's the, when you say he wouldn't have liked, you're talking about the VA doc, because you were taking less pills. Is that what you're saying?
The VA doctor would not have liked me changing the dosage without consulting him.
I see. Yeah. I got you. And how long have you been back on the regular dose?
I went back on April 14th and almost immediately started to feel a little better.
That was my question. Okay. Well, that's really interesting. I may send Chuck Ryan a note and see if he has any thoughts on that, because he's the guru. He was the PI on abiraterone, and I know that he's pretty familiar with playing around with the doses with food, and I could send him a quick note and just say if he's got any idea why, in general terms, not specific for you, but in general terms, why people would not feel as good if they reduced their dose and took the pill. You went from 4 to 1, did you say?
Yes.
Well, I'll send Chuck a note and see what he comes up with. And you started on March the what?
March 6th.
And you went on until April 14th, April 13th?
April 14th.
April 14th. And was there any blood work you did during those 2 periods that showed anything unusual that you hadn't seen before?
There was no blood work in that period. I had blood work done on April 14th.
Right.
But I was feeling so poorly that I wanted to wait until I got those results back. But I felt so lousy. I got the test and then went back on the pills the same day I got the test done.
And when how are you feeling? Weak or sick or nauseous or fatigued or?
Just very, very weak and tired.
Okay.
And prior to this, when I was taking the 4 pills, I was feeling great.
Okay. Okay. Well, if I discover anything, anybody on the call want to talk about that? Has anyone else tried to play around with Zytiga doses?
I've got a couple of questions. Did you change the prednisone amount as well?
No, I did not.
So you took two prednisones with the 1 tablet?
Yes.
Okay. And when you went back to the 4 tablets, did you go back to the fasting regimen, or were you continuing to eat?
Oh no, I went back to the fasting regimen.
Anyone else?
Yeah, Rick, this is Lynn. I actually tried that myself. I was taking 4 tabs of Zytiga on an empty stomach, and then I think it was about 2 weeks, I just decided I'm going to switch to 1 with food. And the following month, my PSA did go down. I'm sorry, I can't recall who was talking before, but unlike his experience, I did not experience any additional fatigue.
Mm-hmm.
I eventually switched back again to 4 just because I was I was very indecisive on whether or not to do it. But I can't honestly say that taking 1 pill a day would be any less effective, and I didn't notice any difference as far as side effects go. But it was only a couple of weeks.
This is Jake. I'm just wondering, maybe Peter had a good point. It might be that the prednisone might be, not cutting back on a prednisone might have been what caused you to feel bad, Tom.
Yeah, I don't know. It could be that, and it just may vary from individual to individual whether that's going to work well for you to do that. Who knows? I want to wait and see what my PSA comes back. I should have it in a day or two. So the next call, I should be able to find out if my PSA rose during the period I was doing that.
You may have actually been taking too much prednisone.
Yeah, who knows? I don't know. I was surprised the oncologist went with it.
Prednisone, I know, can do some strange things to your body if you have too much or too little in your system, according to what you need. One thing you might want to do is send a note to your guy at Hopkins, at Fox Chase, and ask him if the prednisone might have caused these issues.
Mm-hmm.
I think could be worth.
Right now, I just want to get back to where I was, and I'm really kicking myself for, since I was doing well, why did I play around with it at all?
Well, the only reason I kick you is because you were getting your pills from the VA, so it was only costing you $8 a month. If you if it was costing you with your copay was about $2,500 a month, I would have said you had every reason, and don't kick yourself.
Right.
So, but it might be the prednisone. Jake and Len may be onto something there, and I'll see what Chuck says. He may just come back and say, yeah, no shit, he should have cut his prednisone back to half a pill as well. So how much prednisone were you taking? Was it 5 a day, or was it 5 milligram pills or 10 milligram pills?
5 milligram pills, 2 a day.
Two by 5, right? Okay. All right. Anything else for you, Mr. Van Zandt?
No, that's it.
Okay. Anybody joined us and wants to raise something? We've still got 5 minutes, and there was no one else that asked for any time. Anybody else want to talk to us?
Yeah, can I, if no one else is going to take the time, this is Bill Burhans.
Yeah.
I have a question.
Yeah.
I recently started taking Metformin, purely for its anti-cancer properties.
Right.
And I'm having difficulty tolerating it. I started out taking 1 500 milligram tablet each day, and then I tolerated that okay, and then I moved up to 2, and I just get clobbered with nausea.
Mm-hmm.
So does anybody, and any of the rest of you, have any experience with Metformin? And if you do, have you had similar issues? And if that's the case, then do you have a solution to that problem?
Just a word, if I may.
Sure.
I started out at 500 milligrams a day. I moved up to 2 by 500 milligrams a day, and now I'm on 2 by 1,000 milligrams a day.
Okay.
I had this is the weird thing with my body is I haven't had serious problems with virtually anything except bicalutamide, which was a diarrhea thing that was horrible. I had to take an Imodium every day to counteract that. But as far as metformin, my atorvastatin, I'm up to 40 milligrams a day, taking that to battle the cancer. But had no side effects that I noted, and I am pretty careful about what I take.
Yeah. Okay. I'm jealous.
Bill, this is Jake. Bill.
This is Len. I haven't taken metformin, but nausea and diarrhea are fairly common side effects of metformin. And from what I've heard, people who do, develop those side effects, they just back off the dose on the theory, I suppose, that at least some is better than nothing. So you might want to just go back to 500.
Okay. Do you have any feel for whether or not if I just stuck it out, my body might gradually adjust to it, and the problem might go away?
I think you will, Bill. My wife takes 1,000, and she's gotten used to it. This is Jake.
Yeah.
I have a couple of other thoughts. Are you taking it with a meal?
Oh boy, no, I'm not, and I know I should be. Yeah,
you should.
That's part of the problem. That could be.
Take it with a meal, and if you continue to have problems, ask about the extended release version. That's what I take. I only take 500 milligrams. I don't think it's helping with my PSA at all, but I don't think it's hurting. But I take the extended release, so it's a little bit easier on your stomach.
Okay, I didn't even know that there was an extended release version.
Yeah.
So that's a great suggestion. And I
definitely take it with a meal.
Yeah, I forgot about that. I'll do that too. Good, thanks for the suggestions.
Okay, you're welcome.
How
about that? I made a suggestion to a scientist. I'll be damned. You make my week.
Agree, Jake.
There's plenty of room for making suggestions to me.
Mark that down, Rick.
It's all right. It's gonna go on the call notes on YouTube and on Jake.
No, don't do that.
One for Jake.
Anybody else want to talk? Anybody else have any feedback on metformin? Okay. We done it again. 7 o'clock. Just came up on. I guess that makes it 10 o'clock back east. I will say that Professor Burhans is sounding terrific at 10 o'clock at night. The best I've ever heard him sound at the end of a call. Congratulations.
Rick, same thing.
Yeah.
Thank you. I don't know what the hell is going on, actually, but I feel pretty good too.
Well,
I'm going to on Friday. I go under the knife again to have my
pain pump,
intrathecal pain pump installed.
Oh, that's right.
So I expect that I'm going to be sounding a lot better consistently in the future. I hope.
We'll hopefully we'll catch up tomorrow or Wednesday, Bill. I will call you.
Yeah. Okay.
There's so much going on here, but all right, guys. Well, listen, it's a different type of call than we usually have today, but I think that there was a lot of information, and if you didn't catch it all, you can listen on the rerun and see if you can decipher what we were talking about with the biopsies. We will try and follow up. We'll try and figure out what actionable genes are tested for, if there's a significant difference between the solid and the liquid. And again, just mark down on your calendars that May 10th date. It will be a very good session, we hope. So that's it for now. I'll say good night to everybody, and we'll talk again next Tuesday. Yep, today's Monday. Next Tuesday is when we talk again. Okay. Good night, everybody.
Hey.
Good night.
Good night.